As a foster youth, I wish I would have known about all the services available instead of the few that my caseworker chose to share with me. I feel as if there should be something like the grid available for resources for foster children and for foster care alumni that can be easily accessible to all foster youth in all states. Unfortunately, I found out when it was too late that I had missed out on a few resources that I really could have used. So in our next presentation, I think that we need to really consider how can we effectively get resources to our clients and how can we map those resources so that we know that we are presenting our clients with all the resources that are available to them. How can we streamline resources so that we don't overlap and compete? And how can we identify and fill holes where resources are missing? Please consider these questions as we discuss evidence-based models, and I would like to present next Norma Aguilar-Dave, the Savio House Director of Adolescent Services.
Thank you. Okay. Hi, everybody. Okay, can you guys hear me okay? Yeah, all right. So I'm Norma Aguilar-Dave. I am the Director of Adolescent Services at Savio House. Savio House is a nonprofit organization that was established in 1966. We have a very large continuum of care ranging from residential to day treatment, and then service a number of youth and families in our community-based services, from child protection services to adolescent services. We started to do evidence-based models in 1999 and started with MST, multisystemic therapy, then brought in FFT, functional family therapy, then brought in MST PSB, which is multisystemic therapy for children with problem sexual behavior, and then lastly have started doing MTFC, multidimensional treatment foster care. So I'll be talking about all of these different models, the use of the models, why it's important to look at evidence-based models. Please feel free to ask questions along the way. Don't be embarrassed to interrupt. I prefer that we ask questions so that I'm sure that I'm answering things as we move forward. So let me preach to the choir for 1 second. We all have our own set of assumptions and values that we run with when working with families. I'd like to take a minute to identify some of those. And it sort of gives me a point of reference, a way to frame what I'm going to be talking about and why I feel like these things are important. Some of the operating beliefs are all families are treatable, or at least most of them are treatable. There's no one treatment for all families, so assessment is key. It's important to look at families' strengths and look at their challenges, important to look at their protective factors and try to mitigate risk with services that we can put in place. Any family will eventually disengage from treatment if they experience enough failures in treatment. I think we can all agree with that. Kids don't come to us in a vacuum. They have a set of issues and they didn't get there on their own. There's a number of factors that had a role in getting children to where they are and experiencing the difficulties that they may be experiencing. So it's important to take a look at what are all of the drivers to their behaviors, what are the things that led them to where they're at right now. And then most importantly, the best outcomes are achieved with stakeholder buy-in. So treatment teams are key to children's success. Our ability to work together is key to their success. We want to make sure that we position families to experience success from day one. So assessment, as I said before, is key. We want to make sure that we use the evidence-based models that are available to us. These are the models that have been proven to show sustainable success for children and families. And so I'll talk a little bit more about each of them individually and talk about what are the things that tell us that why are they really good at giving us positive outcomes for children and families. Let's look at residential care for starters. When should we use it? We should use it for very short periods of time. There's lots and lots of research out there that I'm sure you all are aware of that talks about where residential programs fall short, that congregate care is not good for children. We have a residential program, and we have decided to keep it as part of our continuum of care, mostly because we believe that there are times when children need to be placed out of their homes, but the length of stay should be short. Our average length of stay is about 3 months. For those children that are going to be returning home, we work very hard to get that family system and that home ready for the child to return home to. So it's less important to look at how the child looks in residential. Those settings aren't going to allow them to look very good. So more important to see how is the family system responding to the interventions that we're putting in place. Are they able to contain that child and their behaviors while they're home? Those are the kinds of things that we want to look for. If we don't have a family system that the child can return home to, then what we want to look at is how quickly can we move a child to a lower level of care, a more normalized level of care, and do it safely, obviously. So are there group homes available, foster homes available that we can surround children with services at that level of care and help them be successful there? It's important to know that young people need positive youth development opportunities so they can engage in healthy risk-taking via constructive, meaningful activities. That's impossible to do in a residential program. It's impossible to expose them to that kind of healthy risk-taking. It should be used to deliver critical, time-limited therapeutic services. Those are the times to use residential. Concerns to consider, as I discussed, congregate care, it isn't good for children. To put a child in a facility that has X amount of other children that are experiencing similar difficulties and are having troubles day to day, it's almost impossible for them to focus on their own issues and be able to work those things through. They have made bad decisions in their lives, and they're attracted to those kinds of things. So putting them in a situation where other children are making bad choices, it's difficult for them to step outside of that and be able to make healthy choices for themselves. Alternatives, we'll talk about one alternative to residential level of care, which is multidimensional treatment foster care. And I'll talk about that in just a second. An example of improving residential outcomes with proper planning is in 2009, Savio has tracked their outcomes for 20 years. In 2009, our outcomes for our residential program showed a 62% success rate upon discharge. A year later, we always do follow-up studies on all of our children that leave our programs. A year later, those same children, there was only a 37% success rate 1 year later for those kids who had left our residential program successfully. In 2012, 74% of children left our residential program successfully. A year later, 68% successful were 1 year later. So there is a huge difference in what we're getting in terms of the success rate for kids a year later, which is what's important. How are they doing once we've provided the service? How are they doing a year later? Are the interventions sustainable? Those are the kinds of things we really should be focusing on. And we're seeing that lowering the length of stay and really working on providing good transition services, really doing good assessments of families, good assessments of children, are giving us better long-term results than when we were keeping kids in our residential program for 12 to 18 months. Do we have any questions about that? Yes?
What was the average stay for the shorter time?
About 3 months, 3 to 3.5 months.
Okay.
Anyone else? Okay. Let's look at evidence-based models. So as I talked about MTFC, MST, PSB, and functional family therapy. Gendro, Bonta, and Andrews wrote an article of what the meta-analysis of offender treatment tells us about what works. And what they found was that on a continuum, to the right were families who received lots of services. To the left were families who received no service at all. And what they found was All the way to the right, our outcomes were horrible, meaning that families that received tons of services, their outcomes were not good at all. So what it tells us is throwing lots of services at families without being purposeful and thoughtful about why we're providing the service and what we're trying to achieve doesn't work for families. Somewhere right in the middle of that continuum, they got the best results. So those families that didn't get no service at all, but the right service at the right time for the right family got us great outcomes. Families won't be able to fix everything, so we need to be purposeful about looking at what are the drivers to the negative behavior that we're seeing in a child. Where does it come from for that particular child? What makes sense about that behavior for that child? And then target the intervention and the service to address those drivers. And then, hopefully, families and children can take the skills that they've learned and generalize it to some of the other issues that they may experience in their lives. The same researchers did some other studies that showed that non-directional treatment didn't work for kids and families. So treatment that just kind of went on and didn't have clear targeted goals didn't work for children and families. Targeted, outcome-driven, and time-limited interventions did work. So things like these evidence-based models that we're going to talk about today, those are the ones that provided positive outcomes for kids and families. Evidence-based models are established in clinical theory. They're empirically supported principles. They have extensive initial and ongoing training for therapists. Trainings usually happen at the onset, so when a therapist is hired, they go through an extensive training particular to their model. They have quarterly boosters, so every quarter our consultant comes in and does quarterly boosters that are focused on individual kinds of issues that the teams are experiencing with their families. So if we're seeing a high number of children that are experiencing truancy, for example, then that's what the booster for that quarter will focus on. If we have a high number of kids that are experiencing substance abuse issues, the booster will focus on that. In addition, there is on-call supervision for clinicians 24 hours a day, 7 days a week. There is group supervision once a week, and then consultation once a week in addition to that group supervision. So clinicians are getting lots and lots of supervision. And the reason that's done is that adherence to evidence-based models is key to the success of the model. So we're constantly looking at, are clinicians following the model the way that they're supposed to? Are they making sure that there are targeted goals and interventions for families? Are we making sure that we're staying on track and that we're not veering off to the many issues that families will present us with, and not veering off to the crisis of the week, but instead really staying focused on what we identified the drivers to be of the particular behavior that referred the child, that got the child referred to that particular program? Questions about that? Okay. MTFC, multidimensional treatment foster care. It is the only evidence-based foster care model. It's best used for children that have to stay, that when we feel like there's a child that needs longer-term placement out of their home. The average length of stay is about 8 to 9 months. They are the only foster child in the home, so there could be other biological children or adoptive children in the home, but they're the only foster child in the home. So a lot of therapeutic intervention is guided towards that one particular child. The kids who normally don't do well in residential programs because they can't handle the amount of disruption that happens in those programs normally do really well in a model like MTFC. We've had a number of children who were really close to getting committed to the Department of Youth Corrections because they weren't succeeding in residential. And so we came to the treatment team and said, let's try MTFC. Here are the reasons why we think it's going to work. We think that the reason the child isn't succeeding is because of the setting, not necessarily because of the child. And so by changing the setting, we're going to try to see if we can create some success for this person. The other part that needs to happen is they need to be able to be in mainstream public school. And treatment teams for these kids who weren't succeeding in residential were saying, well, how are you going to get them to succeed in mainstream public school when you can't get them to succeed in your own residential school? And what we said is just give us a chance to do it. We think we can. That's what we're trained at doing, is going and selling the program to mainstream schools, explaining to them how we're going to be in their school setting, how we're going to be responsive, and help them be successful with this child. And give us a chance, and it worked. We actually were able to move those children into this kind of a model and get a successful outcome. MTFC criteria is there has to be a caretaker that is identified at the onset of the model. So there needs to be either some type of parent or legal guardian that's identified, because as soon as the child goes into the program, we need to start doing family therapy immediately. And when we talk about family therapy, we don't necessarily mean putting everyone in the same room all of a sudden. We're going to skill everybody up. So we're going to be working with parents individually, and we're going to be working with the child individually. When the clinician feels that both the child and family are skilled up enough to get into a room and have a productive conversation and have a productive session, then we'll join them together. We don't want to put them in the room and have them hash out the last 10 years of problems that they've had. They've done that enough. We want to have them be in the room to talk about how the child's been doing well. We want them to get into the room to talk about how they're going to move forward from the issues that they've had in the past. This also could work if there's a foster parent identified from the onset. So if the child is going to go back into foster care, if we have a foster parent that's identified right from the beginning who's willing to work with us and willing to have us in their home, working with them, telling them how to do things, which some foster parents feel like they've been doing this for a really long time and aren't interested in us coming in and telling them how they might have to change things up a little bit for that particular child. But if we do have a foster parent that's willing to do that, we've been successful at being able to transition a child into a long-term foster care placement and be there, for the long term. More optimal, it's not optimal for children who have a history of aggressive behavior. And when I talk about aggressive behavior, some kids become aggressive because of the setting that they're in. So we need to be certain that that's not the driver. If that's the driver, then sometimes just removing them from that setting will eliminate that aggression automatically. But if we think that we have an extremely aggressive child, they're not a good fit for MTFC because it still is a foster care model. So they can't be restrained. Parents need to be able to feel safe in that home. The other children in the home need to feel safe. Those kinds of things. Yes?
The kid back into the foster home the child was in require it to be a foster home? He's the only foster child.
I'm sorry, I didn't hear the beginning of the question.
You're talking, of course. Please hold. You're talking about this MTFC.
Yes.
And you're saying right now about moving a child into a foster home that he was in, if the foster home will work with you. Yes. Earlier you said it had to be a foster home where the kid was the only foster kid. There's other adopted kids or whatever. Is that hold true in this instance?
No, the MTFC home, the licensed MTFC home has to be a foster home that only has that one foster child in it. But a transition foster home that we'll be transitioning the child to does not only have to have one child in it. Sure.
You said that sometimes moving kids from settings make them less aggressive. Are you finding any common characteristics about those settings that sort of led to that aggression?
Yeah. Honestly, it's individualized for every child. Sometimes home and the conflict that they experience with their parents leads to that aggression. Sometimes residential settings leads to that because they have experienced so much trauma that they get triggered by the stimulus of a residential setting and the number of children around them, or by bedtime and what that looks like in that setting, those kinds of things. So it's really pretty individualized per child. But it's a good question to ask as we're trying to assess what service to put the child in and how to treat that child. I think there's Phil, yeah.
Would it be accurate to say that when you put a child into as a single child into a foster home, and with lots of services, that's going to be more expensive than the cost of having that child in residential. But then the idea is to shorten the period of time the child's out of the home so that overall the expense would be less?
Absolutely, Phil. Yes. And actually the expense of MTFC is equal to the expense of residential, and you're able to get a better long-term outcome for the child. Yep. Yep. The other piece I'd want to say, just one second, is that MTFC is optimal if a child has never even stepped foot into a residential program. So what we've seen is that, you know, again, we have a residential program, so I don't want to talk terribly about residential, but sometimes the damage that's done to children from being in programs like that for so long, it's too difficult to undo that kind of stuff. And so by the time they get to a model like MTFC, where people are willing to buy into the possibility of using a model like this, there's been so much damage done that it's hard to undo it. So it'd be best if we could identify children going into a model like this before they even step foot into residential. Yes, I'm sorry.
What about sibling sets? Like if you have siblings that you're trying to work with, is there a way to utilize this model for sibling sets?
Yeah, so that's a really good question. You know, we haven't tried it yet. What I would say is what we'd want to probably do is really assess, do both of those siblings need to be placed out of the home? Is there a way to keep one of them in the home and put one of them into MTFC? Because that we have tried to do, and it's been successful. And then as we're skilling parents up, the child that's in the home is working with that child and using the new skills that we're giving them. Yes.
How does this work? Is this just like a regular foster home? If a child had to be placed through DHS, they could come to look at these MTFC foster homes, or is this something that you're looking at as a treatment model as opposed to placement?
Yeah, the treatment venue becomes that foster home, so MTFC parents go through just as much training as the therapists in this model go through, and any of the therapists in evidence-based models. So they go through training, they have weekly supervision with the supervisor of the MTFC program. We do what we call daily calls, and kids are scored in certain areas. So foster parents have to score them on how they're doing in different areas, and that tells us the areas that we need to focus on with the child. There's a point and level system that the foster parents are trained in, and you know, like I said, the venue for treatment becomes this foster home. So we work really hard to train foster parents at what are the kinds of behaviors you need to be paying attention to, and what are the kinds of behaviors that are just developmental normal behaviors for kids that don't necessarily go unconsequenced, but we don't have to overreact to them either. And so foster parents give points and take points away, but we train them to not engage in power struggles with kids. So the way that it works is that the MTFC supervisor is the one to assign consequences. So whenever something goes on with the child that needs a consequence, the foster parent calls the MTFC supervisor, and the supervisor then gets on the phone with the kiddo and says, you know, so here's the consequence. You know, I heard today that this and this and this happened. They don't even talk about who they heard it from because that doesn't matter. Here's the consequence for it. And then the MTFC foster parent gets to come in and swoop up the child and give them encouragement and say, you know, gosh, that really stinks that Norma just gave you this consequence, but how do we help you be successful now? How do we help you sort of bounce back from this? How do we together work together to make this work for you? And we work from there. So they're constantly the ones to motivate the child and give them encouragement and support, instead of being the ones to have to report all the negative things that kids are doing in staffings, have to, you know, get involved in all of that stuff. They're the ones that are always in the child's corner.
Just real quick follow-up, how many counties have these foster homes, or where are they at?
So we currently have 7 homes. We have 3 coming up. A number of them are in Denver. We have one in Elbert County. We have 2 in Arapahoe. Yep, those are the counties that have it right now. Now we've been able to place kids from other counties in these homes, and it's been able to work fine. We're still doing family therapy with families. what's great is because children are experiencing success in mainstream school settings, it's not difficult to transition them back home into a new school. There is an aftercare part of this model that follows the child when they go home. So we're still around to make sure that they're doing well in school, that they have lots of things to occupy their time, lots of good extracurricular activities that they're interested in and are successful at. So, so it's been able to have have other counties place kids, even though it may not be in a home that's in their county.
So am I right in understanding that if the child needs day treatment, which if they've been in an RTC, they've been receiving, so if we take them out and do this, they're going to have an IEP that has certain legal requirements to it. So you're not even going to consider those kids for this model?
Not if the team believes that they have to be in day treatment. The only thing I would caution everyone around is that even those kids that we all feel very strongly have to be in a day treatment program, honestly, some of them don't. When you can put them in a mainstream school setting and surround them with services like this, they really are able to succeed. There's been children that even I questioned whether or not we were going to be able to pull it off, and they've been able to make it work. And kids are, playing volleyball and doing normal kinds of things that they should be doing, and we're teaching them how to do that and how to do it successfully.
So they can have an IEP.
Yes. Yes.
And those things will be in place, those services. It's just that all those services would need to be delivered in a mainstream school.
Absolutely, yes.
Okay.
What extra training are you giving the foster families that are involved in this, and what requirements do you make of them that you don't make of other foster families?
So obviously they receive the same training that all foster parents do because they have to, everything that's dictated to us by the state. As I mentioned earlier, we train them in the MTFC model, which is just really guided on what their role is. MTFC is a very strategic kind of model, so everyone has their role. Foster parents have a role, individual therapists have their role, family therapists have their role, and then we have skills trainers also that are assigned to every case that go out and practice normal skills with kids, and I'll talk about that in a minute. But they're trained, like I said, on how do you sidestep power struggles with children? Why does that make sense to do that? We train them on the point system because it's really important that they adhere to that point system and adhere to it well. They are part of the treatment of the child, so adherence to the model is key. So we're constantly looking at what is that foster parent's ability to adhere to the model that they're supposed to be working within. The skills trainer works on really normalized skills, so not therapeutic skills, but normal things. How do children walk into a place and look at someone in the eye and say good morning? How do they go into a McDonald's and order something and get the wrong order and not flip out and start cursing people out? How do they just do normal things, right? And it's been amazing, the change that we've been able to see. We have skills trainers for our children in residential, in our residential program also. And it's amazing to see how, a kid comes in, sort of kind of a grumpy kid and doesn't really know how to say hi to people, and within a couple weeks, they're saying good morning to their teacher. Those are skills that are huge for children, skills that they need to learn that make a huge difference on whether or not their teacher is going to be willing to take a little bit of extra time with them, to be a little bit more patient with them, right? Because all of a sudden that kid, that grumpy kid that nobody really liked, all of a sudden has a really nice affect and can say good morning to people and be liked by people. And so those are the kinds of skills that skills trainers are working on. So if you enter a staffing and you say, well, I'd really like, this kiddo to work on, this particular therapeutic skill, the team's going to look and say, that's not the skill that we're going to work on with this child. We really feel like he or she needs to work on these sort of more normalized things instead. I think there was a question back there.
That program sounds a lot like the Bring It All Back Home program out of North Carolina,
Okay.
which had highly trained foster parents and felt that that was probably next to the governor, the most important trained position in the state. Are you paying your foster parents more than the average foster parent is being paid?
Yes, yes.
How much?
They do get paid quite a bit. They start out at about $1,900 a month, and after a couple of successful discharges, they go to $2,100 a month. So they do get paid well. These are really hard kids that we're asking them to work with, and so we want to provide them with lots of support. They have 24-hour days, 7-day-a-week support from us. They can call the program supervisor at any time when there is a problem. They have respite. We have respite built into the model. So they get 2 weekends a month of respite. They don't have to use it if they don't want to, but they certainly can. We believe that that is important. And we explain all of this to the child. We want to make sure the child doesn't feel like they're just kind of getting shipped off for the weekend. We explain why those things are important. And as soon as we can start doing passes with their family, those respite, that respite will be hopefully that the child is going on a pass with their family. And we want to try to do that as soon as we can. But again, we want to set everything up for success. Families have experienced enough failures, and so we want to make sure that we're doing passes when we're certain that we've skilled them up enough that if something does happen, parents are able to deal with it. Perhaps they may call us and they may need our help, but that they're equipped to deal with it, and we're not going to have a big blow up and then everything's going to take us back. Other questions? Yes.
What about for a developmentally delayed kid?
Yeah.
If he's able to maintain in a public school?
They have to be able to really understand the value of the point and level system and understand how that works for them. So it'd be a matter of assessment. The model isn't proven. They haven't done any studies with developmentally delayed with that particular population. So we don't really know whether or not it works. We have had a borderline child of an IQ of 70 in the program, and it was fine. But we just have to make sure that they can really follow that point and level system and really understand it and understand the value of it. Other questions? Okay. Let's move on to MST, multisystemic treatment. The goals of MST are to reduce youth criminal activity, reduce other antisocial behaviors. It's a community and family-based treatment, and we want to achieve cost-effective outcomes to reduce incarceration and kids in out-of-home placement. So the model is intended to be in lieu of out-of-home placement. The hope is that we use this model to reduce the number of children that go into out-of-home placement. So for those kids that are at severe risk to be removed from their home, this is a good model to use. It is scary to keep kids in communities. It's scary, especially when we don't think we have parents who can contain the child's behavior. But with help, they really can do this stuff. And so, if we can keep a child in the home, we should work really hard to do that. It's more of a parent-focused model, so we need a parent system, whether any kind of caretaker system. So if it's a grandmother, an aunt, an uncle, a parent, whomever, who we can engage, somebody that we can sink our teeth into and really work with. So when I say that, I don't mean that we need to have them engaged from the onset and saying, oh, sure, I'm willing to do MST. What I mean is, do folks that have worked with this family before, do folks that know this family think that we can get them engaged in this process? It's the therapist's responsibility to provide engagement for the family. So it is our job to make sure that a family is engaged. If they're not engaged, it's our fault and our problem. And we work very closely with our consultants to continue to figure out why the family isn't engaging and continue to try interventions around that. But one of the first things we're going to do when we go out to do a pre-placement interview for a family is gauge that engagement piece. Do we see the kinds of ingredients that we're looking for in a family that we believe will give us the kind of engagement that we need? Because it is mostly parent-focused. There's little intervention that's done directly by our clinicians with a child. Most of the interventions are done with the parent and the child. And so the parent is driving that intervention with our coaching and help. Does anybody have questions about that? Okay. Sorry. Okay, so program overview, what's MST? It's an ecological approach, so it views the youth as embedded within multiple interconnected systems, including the nuclear family, extended family, neighborhood, school, peer culture, and community. So it's an ecological model that is going to look at all of these different venues within that child's world and really try to address interventions that target all of these different areas. A child didn't, like I said, a child didn't get here on their own. So the way that MST looks at it is it's saying all of these different things played a role in this child's experience and in the difficulties that they may be experiencing right now. I'm sorry, what?
Question was who pays?
Who pays for MST? So most referrals come from Human Services, from the Department of Human Services. We do, Senate Bill 94 can pay for the service as well. We do have some families that are able to pay privately, and we're able to do that. We do are able to have Medicaid pay for some cases also. Probation pays for some cases. So there are a number of different avenues, a number of different ways. For example, an MST intervention might be that if we think that peer culture has a lot to do with the problems that the child might be facing, we will coach parents and teach them to invite all the kids' friends over for a pizza party and start learning how do you interact with your child's friends. What kinds of questions do you ask them? How do you sit at the table and have pizza with them and you know, get to know who these kids are? Because those things we know are huge in terms of parenting a child. So, and it's amazing the number of families that don't know how to do these kinds of things. And yet amazing the difference that we see once families are able to start doing this, and the difference that we see in the kinds of kids that their child is choosing to spend time with now, because now all of a sudden you're gonna have to bring that kiddo home sometime for mom and dad to look at him or for grandma to see him or those kinds of things. Okay. Referral criteria for MST, youth ages 10 to 17, chronic juvenile offenders, like we talked about, at least one engaged caretaker, youth who are at risk of out-of-home placement. MST research, there have been 13 randomized clinical trials that have been published, and when we look at MST versus traditional treatment, there was decreased rearrest rates 25 to 70%, decreased days in out-of-home placement 47 to 64%, and MST also decreased substance abuse. The way that MST will look at substance use is it will be very individualized. What are the drivers to the substance abuse for that particular child? So they're not going to use group work. They may use UAs if it makes sense for that particular family, but they're going to be using parents to do those kinds of things. So, you know, how do parents pull UAs on kids if those are the kinds of things that they're interested in doing? How do they use the information that they get from a UA? Because how is that important, and how do we use that in treatment for children? They're looking for evidence of a problem. So are there areas in the child's life where their substance use is causing problems? It can't just be that because a child goes out and smokes marijuana every now and then that we believe they need substance abuse treatment. There needs to be some real evidence that shows us that it's hindering them in some area, in some facet of their lives. Questions of that? So MST was also proven to be significantly more effective at decreasing problems in youth, behavior problems in them, decreasing youth criminal offending, decreased parent and youth symptoms. So we saw a large number of parents be able to increase their warmth and affection towards their children, which is huge in adolescence. Even though they don't want it very often, it's still really important to do it and to be able to offer it and not be angry at them all the time. Increasing family cohesion and adaptability, decreasing youth association with deviant peers, and decreasing youth aggression in relations with peers. That also showed significantly more effective at improving youth grades in school. MST sees families as a solution, and engagement is the key to success. So we won't look at resistance as being the bar to treatment. We'll look at it as being a possible barrier, one barrier in many. Our clinicians don't use the word resistance. They're really not even allowed to in consultation or anything like that. They're not allowed to even talk about that. What they talk about is, I'm not able to engage the family, so what are the kinds of things I need to be doing differently? Therapists are trained to align with parents, so that part is very important. I know that we often hear, well, the therapist doesn't see, the number of things that the parents are doing wrong. And it isn't that we're blind to that. It's that they're trained to look at things a little bit differently. They're trained to be solution focused. They're trained to be to look at the positives in things, to look at the strengths. So I know a number of times I'll get calls from people complaining about that issue with them saying, well, the therapist is just naive, they're not paying attention to things. But honestly, it's not that usually. It's usually that they're just using their training. They're looking at the family the way that they're supposed to be looking at the family and trying to overcome barriers and not only focus on the negative things that are happening within that family system. That is what they use to motivate families to create change. Questions? Okay. The 9 principles of MST. Finding the fit. What are the drivers to the behavior? We do fit circles. You put a behavior in the middle and then lines going to that behavior. And we do this in consult. We do it with families. We do it with children. And so we're asking, what are the drivers to that behavior? And then we rank those drivers with families. What is the biggest driver? What's the thing that you think is truly driving this behavior in that child? And that's what we're going to focus on. Those are the things that we're going to target our interventions with. So we're constantly doing those. These fit circles are done weekly with families, weekly with a consultant, to make sure that we're targeting the right intervention and we're targeting the right behavior. Positive and strength focus, like I talked about, increasing responsibility. So increasing responsibility for parents and for children, making sure that we're teaching them how to make responsible choices. Present focus, action-oriented and well-defined. Targeting sequences. So interventions should target sequences of behavior within or between multiple systems that maintain the identified problem. Developmentally appropriate, we want to make sure that interventions are developmentally appropriate. We want to make sure that we are teaching parents developmentally, where should that child be? What are the kinds of things that are normal for them to be doing, that are just part of being an adolescent? Continuous effort on the part of the clinician, so we're going to constantly be working it. What MST says is whatever it takes. That's exactly what we're going to do. So clinicians could be in the home 15 hours a week, or they could be in the home 3 hours a week. It just depends on what that family needs at that time. Evaluation and accountability, we're constantly evaluating our interventions in consult, making sure that the interventions are working, and if they're not, we're going back to those fit circles, because if the interventions aren't working, then it's probably because we've identified the wrong driver. And so we need to go back to those fit circles and really identify what is it that's driving that behavior. Generalization, making sure that we are putting interventions in place that can be generalized to other behaviors that the child or other children in the home may have. And treatment adherence, making sure that we are adhering to the model. There are a number of ways that MST looks at, sort of rating our teams to make sure that we're adhering to models. And so there are TAM scores, and they call families to make sure that, the interventions that we're putting in place are really MST-guided interventions, those kinds of things. So we're constantly looking at making sure that our clinicians are adhering to the model. Delivery of MST, it's in the field, usually lasts about 3 to 5 months. The intensity is 2 to 3 times a week. Staff availability is 24 hours a day, 7 days a week. And the treatment outcome is on the staff and the agency. There are boosters that are offered for MST. So for clients that have had MST services, if 6 months after they discharge, a year, or whenever after they discharge, if they're still involved with people, anybody can call. The family can call even if they're not involved. Family can call, GAL can call, probation, a neighbor, whomever, can call us back and say, the family is starting to struggle again. What we'll do is we'll come out and do what we call a booster session with the family, bring out their sustainability plan, review with them, what were they doing when things were going well? When they discharged positively, how were they handling situations in their home? And getting them back to that place again. Often, that's enough. Sometimes, not very often at all, we may have to reopen the case and service them for a little bit longer. But that really doesn't happen very often. Usually we're able to, within that booster, just go out and do that. There's no cost for the booster session. So, if a family is struggling, before we look at putting another service in, give this kind of thing an opportunity. Give us a call, let us know, and we'll come out and do the booster session. Okay, we're going to talk about offense-specific kids. So non-PSB, so non-evidence-based, non-problem sexual behavior, juvenile sexual offender treatment. How much do we know? We don't really know a lot. There's not a lot of research that's been done on traditional offender treatment. There's no outcome data. There's no real evidence that it works. What are the things that we need to be concerned about when looking at traditional offense-specific treatment? Most treatment approaches focus exclusively on altering youth's individual characteristics. So most treatment approaches are focused on the youth as an individual. They're not family-focused interventions. They're patterned after existing interventions with adult sex offenders, which research has told us that we shouldn't be looking at juvenile sexual offenders the way that we look at adult sexual offenders. The recidivism rate for treated juvenile sex offenders is less than 6%. That isn't the case for adult offenders. Treatment programs are based on theories about deviant sexual arousal, relapse prevention, and abuse cycles. So often we'll hear, folks wanting the child to recite their abuse cycle. Well, not every child literally goes through that abuse cycle. For some of them, that may not be the case. So what we really want to try to do is teach them their sequence. So what is it for them that makes sense? How did they get to that particular place? Those are the things that are important. Treatment usually lasts 12 to 24 months. Individual sex offender specific modules and often involve group therapy. We've talked about congregate care and how that doesn't work for kids. Group therapy isn't necessarily a great mode of treatment for children either. To sit in a room and have them talk about their own offenses sometimes exposes children to things that they shouldn't be hearing. And it's, it's embarrassing to have to talk about that. And there's no research that says that that embarrassment lowers risk. Treatment seldom adheres to the principle of least restrictive setting and is delivered with minimal ecological validity. So we're not looking at the ecology of the child and trying to use the protective factors in that ecology to mitigate the risk for that child. Treatment seldom considers developmental differences between juvenile and adult sex offenders, and usual treatment bears little resemblance to effective treatments for other serious antisocial behaviors. This is where MST-PSB came into play. So what it is a family and community-based treatment approach designed to promote victim safety and reduce the likelihood of future sexual offending and other non-sexual criminal activity. Again, families are seen as the solution, and families and community supports are the long-term agents of change. So it's driven very similarly to MST. The goals are to eliminate sexual offending, eliminate or reduce criminal activity, address youth and familial denial about sexual offenses, develop and implement individualized, comprehensive, and ecologically based treatment to ensure safety, and emphasize long-term change that families can maintain after discharge. Children need the opportunity to socialize in a healthy way, to learn healthy sexuality. And when we put them in places like a residential setting, there's no opportunity in those settings for them to do that. Referral criteria: youth have been involved in problem sexual behavior, 10 to 17, at least one engaged caregiver, at risk for imminent out-of-home placement, and youth who are reunifying home from placement. So the thing to think about in regards to that last bullet is that, I think historically we have thought that kids need to complete offense-specific treatment while they're in residential level of care, but that really isn't the case. Again, we want to make sure that we have a system to contain them, and that's really the important part of it. They can finish out their offense-specific treatment while in the community as long as we can keep them safe and the community safe as they transition out. I'm going to move fast because I'm out of time. So the correlates of juvenile sexual offending were very similar to that of, that they found in MST studies. So individual factors, family factors, parental problems, peer relations, and school performance. Those were the things that studies showed in PSB that were right in line with juvenile sex offending. Bordoon, Schaefer, and Heblum did a 9-year follow-up study, and what they found were kids who received traditional offense-specific therapy versus kids who received PSB. What they found was PSB was significantly more effective at sexual reoffending. The recidivism rate for children who had received PSB services was 8.3%, and for traditional services was 45.8%. Preventing other criminal offending, 29% for PSB kiddos versus 58% for traditional. Decreasing days incarcerated during adulthood by 80%. I won't go through this because that's not really important. They all have a copy of this PowerPoint, right? Okay. So we won't go through the clinical adaptations either. Delivery of MST, 6 to 9 months, 3 to 5 times per week. Same 24/7 availability, and the outcome is on the shoulders of the staff and the agency. For PSB kiddos, Savio, kids who had received PSB, Savio's outcomes, 91% of children who received PSB services completed the program and discharged successfully. 86% were successful 1 year later. So out of those 91%, 86% were still successful 1 year later. Functional family therapy. It is more of a family-based model, so MST is going to be more of a parent-based model. FFT is going to be more of a family-based model. We want to see all the people that are living in that home. The intensity is not as intense as MST. It's usually 1 time per week. So often people feel like it's not intense enough. But really, both models would say they could service the same child, having the same family, having the same problems. They're just going to go about it differently. And I'll talk about that now instead of later. So MST is going to look at a family and say, so if this child is experiencing difficulty because of ecological factors, school, peers, those kinds of things, the community that they live in, MST is going to be a much better fit for that child and family. Because it's more intensive, the family has to be able to tolerate the intensity of the model. Okay? FFT is going to say, if the child is experiencing difficulties because of what happens in the 4 walls of their home, because of the parent-child conflict, because of the communication patterns within the home, FFT is going to be a much better fit for that family. So if it stems from the family system, FFT is going to be a better fit. If it stems from the ecology of the child, MST is going to be a better fit. Referral criteria, youth ages 10 to 18. FFT seems to work best with older kids. So when you have a 17-year-old, MST doesn't work as well. Parents usually don't want to parent that child that much, and that 17-year-old doesn't want to be parented that much. So MST isn't going to be a great fit for those kids. Delivery is 12 to 15 sessions, usually one time per week. There is 24/7 crisis calls that we take as well, so if the family is in crisis, they can call us. So now we're going to put the operating beliefs into action. Since all families are treatable, then resistance shouldn't be a bar to treatment. We have to believe that families can do it on their own. We have to believe that they are the change agents, and that although everything can't be fixed, we can address the things that brought them to us and then let them work on the other things as they move forward, generalizing the skills that we've been able to teach them. As there's no one treatment that will work for families, then we must consider family strengths and challenges and identify the models that are proven to provide desirable, sustainable outcomes. It's important to assess families, ask key questions. What brought them here? How did they get to this particular point in their lives? What are the things that they think they need in order to be successful? And then only give them those things. Only put in services that address those particular things. I just talked about the MST versus FFT. Since any family will eventually disengage from treatment if they experience enough failures, then individualized treatment plans are imperative. There are lots of venues, lots of counties have venues to do great assessment work. Arapahoe County has a links meeting that they have. I'm sure you guys have all participated in those at some point or another. It is a great venue to do exactly what I talked about. Ask questions, really assess a family's strengths and weaknesses, really look at what the protective factors are that they have to help them mitigate their risk, those kinds of things. Jefferson County has options meetings. I sit on those option meetings, so there are providers there to help with their expertise and work with people at really knowing what kinds of questions to be asking. Denver has a SART team, the Sexual Abuse Review Team. Tom Leversey from the SOMB sits on that team. There's a victims person on the team. So there's lots of expertise on that team to ask the necessary questions to figure out whether or not we can keep children in communities safely. And then last but not least, kids don't, actually that's not true, it isn't last, but very close to last. Kids don't come to us in a vacuum. We have to treat both sides. When we have families to treat, we have to make sure that we're including them. We have to make sure that we are helping them be responsible for helping them show their child that they accept some level of responsibility also for why the child got to where they are. Those things are really important. Sometimes residential programs allow families to check out and to get a break from kids, and that isn't healthy for children. Now, last but not least, the best outcomes are achieved when you have stakeholder buy-in. This, I can't stress enough, how important this is to really make sure that we are working together, that we're listening, that we're remembering our roles on the treatment team, that we're making sure that we are trusting of one another, and as providers that you've put us in the job of providing treatment to kids, that you trust what we are trying to do with them. Certainly ask questions. Hopefully this has been able to give you a little bit more information about evidence-based models so that you can be part of treatment planning for children and asking the right questions around why does that make sense? Why does it make sense to place them in residential? Why doesn't it make more sense to keep them in communities? Those kinds of things. Does anybody have any questions? I think I went over.
I have one question about PSB. When you talk about your successful outcomes and they're successfully completed, is that your program is completed, or does that include kids who are on probation and need to complete the required SOMB treatment? Like, have they completed all of that within your program?
So PSB is an SOMB sanctioned treatment. So when they complete our program, they should be done with all of their offense-specific work. when they complete PSB. Does that answer your question?
I think so. So when you said it was, I don't remember the percentage.
91, I think.
91%. So you're saying that 91% of your clients that finish your treatment are to a point where they are getting off probation, or at least receiving that successful completion letter?
Yes, a successful completion letter. Unfortunately, not necessarily off of probation, although we'd like to think that they're on their way to be off of probation. The other thing about evidence-based models is that once the model finishes, that really should be the last treatment for kids. What research has showed with all of these models is that when kids finish with an evidence-based model and then we put in more services, we end up with a negative discharge. So we really need to let them go at that point, let them use the skills that we've taught them and see how they do, and usually they do pretty well. So for most of the kids that we see that have a negative outcome a year later, a large percentage of them have had another service put in afterwards. And so there's some question as to why that is.
Do you provide services beyond the San Luis Valley? Can I use Savio House services in the San Luis Valley?
Well,
that's my question.
We do. Tell me where the San Luis Valley is. So, I mean, we have
San Luis Valley, Alamosa, Colorado.
Yeah, we don't go as far as Alamosa.
Thank you.
Unfortunately.
But if we have kids who are already placed in the metro area from the San Luis Valley, would they be able to access Savio?
Yes.
Fantastic.
And we have an office in Colorado Springs, so we go all the way to Pueblo. We have 2 offices in Denver, and then we have an office in Longmont. So we go Larimer County, Weld County. There are a number of kids from outside counties that are placed in our residential program, and then we're working to get them home very quickly, or to a foster home or group home. Any other questions? All right. Thank you. Thank you very much.